Good morning or good afternoon, depending on your time zone. Welcome and thanks for joining us for today's HIStalk webinar, How Clinically Integrated Networks Can Overcome the Technical Challenges to Data Sharing. It's brought to you by Liaison Technology. I'm Lori from HIStalk and I'll be moderating. We have two speakers today. First up will be Gary Palgon. Gary is the Vice President of Healthcare and Life Sciences Solutions at Liaison Technologies. Joining Gary will be Dominic H. Mack, MD. Dr. Mack is Executive Medical Director of the Georgia Health Information Technology Extension Center and Georgia Heath Connect, and is Director of the National Center for Primary Care and Associated Professor at Morehouse School of Medicine in Atlanta, Georgia. And with that, I'll turn it over to you, Gary.
Great, thanks, Lori, and thank you guys for taking part of your busy day out to listen to the webinar. We'll be covering how clinically integrated networks can overcome the technical challenges to data sharing. Interoperability, a key part of this, can be easy in the cloud. And as Lori had presented, both Dr. Mack and I will share and providing as much educational information to you. So here's what we'll discuss today. First, I'll talk about the objectives of what you should be getting out of today's webinar, and then give an overview about clinically integrated networks and the interoperability challenges, everything around data and moving data between different organizations, different applications, and the challenges that organizations run into that. Then we'll turn it over to Dr. Mack, and he'll be covering the MACRA requirements as a driver for data sharing. So he'll give you a real example of the stuff that he has worked on within Georgia Heath Connect, as well as the Morehouse School of Medicine, share some of the lessons learned, and then give an actual example of Georgia Heath Connect, which is a clinically integrated geographic-based network. And then finally, I'll come back and give you some hints and tips on the technical requirements that you need to look for, introduce you to the concepts of the industry solutions, the options that you have for both on-premise and then a focus here of cloud. So you'll get the full idea of what is included and what you have to choose from. And then finally, any questions that you have for Dr. Mack or myself, we're happy to entertain those as long as time permits. So anytime during the webinar, please feel free to submit those and we'll make sure that we address them at the end. So from an objective standpoint, first thing to understand is what challenges around interoperability exist and what need to be thought of. And so some of the topics that we'll cover are the standards. We'll talk about the actual codes and documents, the formats of those documents, things that are needed from a data governance, and also how does a geographic location or the size of the network play a part in those challenges of exchanging information. We'll talk about some best approaches and how you can link that together. And again, there's different situations, hospitals, practices, and in the cases Dr. Mack will cover some of the challenges he has as he's covering the state of Georgia and interoperability both nationally and surrounding states with some small and rural practices. So that always is a challenge of how you deal with the last mile. You'll talk about the case study and the MACRA requirements and how that drives the need to exchange the information. And as I mentioned, talking about the technology and industry options for that secure exchange. So hopefully at the end of the webinar, you'll be able to feel a little bit more confident and comfortable about what needs to be done to be successful there. So let's spend a couple minutes just talking about a clinically integrated network and the interoperability challenges for it. So what is a clinically integrated network? And there's some other terms that are around there, but essentially it's a collection of different providers. And so all types of caregivers, physicians, they could be in a hospital, it could be in a post-acute or ambulatory setting. And together, the goal of that set of individuals and set of organizations is to obviously improve the patient care and also to reduce the cost associated with that care. So definitely a couple of the components of the triple aim. And at the end, and when I say end, it's periodic checking along the way. What a clinically integrated network should generally do is obviously show that you're improving the quality and the efficiency of the care. There's goals around achieving measurable targets. And so you know that any time that you have measurable targets, there's going to be a need for data and a need for sharing across that. And of course, monitoring both the individual physician as well as the performance of the network to get feedback. And then finally, there's going to be a need of collective financial investment, and that's going to be needed for the type of reporting systems that are out there. There are various purpose-built specific applications or custom bespoke applications that may be needed for the type of network that you're working for. So what becomes important as we cover interoperability and the challenges, if you read between the lines, is it all requires integration of systems, integration of applications, and the interoperability of that information. So let's talk about the challenges with regard to the data itself. I think we all probably would attest that integration is different, and so difficult. When we talk about that, there are different partners, different size partners. Oftentimes we're dealing with point-to-point connections as opposed to a scalable model where everybody can connect. And again, looking back in the history, you know, email used to be point-to-point, and now it's global, where we can really, as long as we have an email address, can reach anybody pretty much throughout the world. There are different protocols, meaning the types of ways of pipes, if you will, between the entities, and different formats for the documents. And when you hit an endpoint, what is the type of EMR or EHR or application that you're trying to? And some have very openness, APIs or ways to communicate and get data in and out of those systems. And others are closed, which becomes a barrier or a big challenge when you're trying to, again, facilitate this integration and sharing of data throughout the network. When we talk about standards, there's a couple adages that come to mind. One is you've seen one, and that's if you were talking about a specific HL7 format or EPIC in a given release. So standards are good guidelines. I like to say that a standard is probably the only one-word oxymoron out there, because we say and like to think that everything is standard, but the problem is there's a lot of standards, and what we need, as we'll dig into it, is those various standards to be able to communicate one another and an understanding of what that means. So there's many different terminologies, and we'll cover more than the technical aspects in this webinar, but also the context of it. What is the the dialect that may be there, and does that affect? So if, you know, two Russian individuals were trying to communicate, what is the, you know, maybe they have different dialects and it's tough to communicate. And then finally, capturing all the necessary data in EHRs or EMRs, they don't always have it. And I think if we look to the right here, this is a set of quote standards, the standard plugs that are used for devices that need electricity throughout the world. And so, you know, in the United States, we can say, yeah, we all use the standard that's in the top left and number 2. But the problem is you go through Australia down under, New Zealand, there's a standard. If you go to some of the Asian countries of China and Japan, it's different. If you go to Europe, it's different. So how do you make all of those? How do you get electricity out of those? And so there's a bunch of different converters, and effectively that's what we're trying to do, is how do we get it so that the conversion between different EMRs and different systems and different practices becomes pretty simple. And as simple as going on Amazon and buying an adapter that'll let you communicate and exchange electricity with different outlets and different devices throughout the world. And there isn't one single device, but you can get pretty close through the years for that. So with that, taking that information up, I'm going to turn it over to Dr. Mack, and he'll walk us through some of the MACRA requirements and some of the stuff that they've gone to. And he can start you off with first an introduction about himself and Morehouse and the National Center for Primary Care. So I'll turn it over to you, Dr. Mack.
Thank you, Gary, and I want to thank everybody for being on the call. Today, we want to tell you about, as Gary said, one model of a clinically integrated network. And we've been working with Liaison over the past few years to build a health information exchange and connect to providers across the state and across the Southeast region. First, let me just tell you a little bit about Morehouse School of Medicine. Morehouse School of Medicine is a mission-based institution, and within that is the National Center for Primary Care, for which I am the director, and where we have our technology center, where we've been working with providers that are stated across this state and the Southeast. What we're doing is we're focusing on quality and quality implementation of health information technology in underserved areas, with a focus on health disparities and achieving health equity across this country. Next slide, Gary. So we have a number of services to help providers. We've helped over to this point, about 6,000 providers and 56 critical access and rural hospitals across the state of Georgia. And we are doing some work now across the Southeast around quality measures and helping providers to meet quality metrics, and that kind of rolls into MACRA. And what I'd like to do is just tell you a little bit about MACRA. MACRA is the Medicare Access and CHIP Reauthorization Act. It's a QPP, Quality Payment Program, that's going forth in this country, which is we're changing from a volume-based payment system to a value-based payment system. This is an initiative that has been put forth by CMS, the Centers for Medicaid and Medicare, and it's focused on Medicare providers. And a lot of people don't know, but CMS, Medicare, and Medicaid take care of nearly 50% of the population when it comes to insurance. So the way of CMS is the way that the insurance industry will go. And what this bipartisan law does is it creates a new framework for provider reimbursement, and it consolidates existing quality reporting programs with a budget neutral agenda. MACRA is the legislation. CMS has developed a quality payment program, which providers on Medicare who qualify this program will actually have to testify, attest to, or submit quality data in order that in the year 2019 they will be paid according to this value-based system. And it does positive and negative payment adjustments. It does account for the provider's reputation and how they're perceived across the healthcare industry. But early adopters get ahead of the workflow when they establish a baseline and enter the program early. So we'll tell you a little bit more about that. Next slide. So MACRA, there are basically four components of what we refer to as the MIPS program, Merit-Based Incentive Payment System. Within this, you've probably heard of PQRS, the Value-Based Modifier, and Meaningful Use programs. Well, these four components, these have been put into four components within the MIPS program, which are known as quality, costs, advancing care information, and improvement activities. We're focusing on the advancing care information section today, which was previously known as meaningful use. Now, what the MACRA program does is it kind of ratchets up the requirements for practices across this country when it comes to health information technology. And what we're focusing in on today is the health information exchange. Providers going forward will have to be able to exchange information, join health information exchanges, and also other exchange mechanisms such as clinically integrated networks, which we're referring to today. Next slide, please. So we're focused on addressing the needs of underserved populations with this clinical integrated network. If you look at the data, it shows you that the rural communities, some of the underserved urban communities are having issues when it comes to EHR adoption, having the resources within their practices to meet quality metrics, to join the patient-centered medical home model. And of course, we're having an aging population. Today, the population by the year 2050 will be, the aging population will double, and the amount of folks over the age of 85 will also double. Well, the elderly, most people over 65 have at least one chronic disease, and we know chronic disease comes into that cost and the improved care that is needed within the system. So all this burdens the system when it comes to population health. And what these models, such as clinically integrated networks, do is they attempt to improve the way we manage that population, which is called population health management. So there are many challenges, but what we're trying to do is put models in place that will address the challenges of those smaller practices and smaller hospitals that have less resources to integrate with these new quality metrics and these new quality systems. Next slide, please. So let's talk a little bit about Georgia Heath Connect. And Georgia Heath Connect is our health information exchange. And within Georgia Heath Connect, we have the clinically integrated network that we're talking about today. First, as we stated before in the previous slide, the issue is the connectivity and the integration of information today. Different EHRs have better interoperability than others. We have a lot of people who are connected to the health information exchange, but we're trying to move to the point where we have true interoperability, and that is the ability to actually exchange useful information. And in the clinical integrated network, what you do is, say for instance, in a rural community, you begin to connect providers who need to share information about the patients that transit when you think about care coordinations, they refer to each other, or they need to share imaging information on a patient to improve outcomes. Most health information exchanges today are in metropolitan areas, and in these people outside of the metropolitan areas may not be connected to the health systems that sponsor these health information exchanges. So there's a need, especially rurally, to have more clinically integrated network, because within the network, you have a specific population of patients, or subpopulation of patients, and you can implement quality metrics. Some of these metrics can be autonomous to the CIN, but they can also be those metrics that are required by MACRA. You can better manage those metrics, identify gaps, implement new programs, and measure those the success of the outcomes that you have within that system, and therefore continues on a continuous quality loop to improve the care of that population. Next slide, please. So what is the information that we bring to the network? Once someone joins the clinically integrated network, they're within an HIE that's connected to the state agency. In our case, in Georgia, with the state agencies, we have the Medicaid system, we have the Division of Families and Children's Services, and what's really needed in all communities, of course, is the Georgia Department of Behavioral Health. We know mental health is a major problem, especially when these patients leave the primary care practice and they get lost within the community. So we're able to have that information and connect to that information. There are insurers on our state HIE called a GN, Mary Group, Peach State, and WellCare, and there are others that are joining. So you not only get the claims data from Medicaid, but you also get other clinical information from private insurers. Major healthcare systems such as Emory, Gwinnett Medical, and Grady Health Systems are on this network. And then you have your regional HIEs throughout the state, in which we are one of those regional HIEs. Specialty connections include the Georgia Partnership for Telehealth, which is connected throughout the Southeast, and actually some national connections. And then because of our connectivity and our participation within the state HIE, we're also connected to surrounding states in the Southeast, and we actually skip over into Texas. Next slide. So how do we operate as a HIE platform? Well, it's built on partnerships, and we've had a valuable partnership with Liaison as our technology partner. As a state Morehouse, we are a clinical entity, but a technology entity. We have a membership with providers in the community. We understand the needs. We've implemented quality programs like Meaningful Use, but also patient-centered medical home. So we are the practice management wing, but Liaison is the technology partner that helps us connect to all the practices, these EHR systems. Another one of our partners that's pertinent to this model is the Georgia Department of Health. We've been involved with the Georgia Department of Health and Medicaid within the state since we began this program working around meaningful use. So what we're providing now is MACRA education, connectivities to the Department of Community Health Clinical Quality Initiatives, membership management, as I stated, PCMH consultation and practice management services. So we think this helps the providers who join our clinically integrated network to almost operate as a virtual ACO as we bring better reporting and analytics to the system. Next slide. And you hear a lot about virtual groups within the MACRA model. So as we talked about earlier, small practices and small hospitals are closing. What we're trying to do is enable them to stay into practice, not only be able to connect to each other in smaller communities or rural communities, but also exchange that information, develop that community patient record, develop the analytics and the reporting so that they can improve quality within their practices at a affordable cost. What's happening today with some of the larger technology and the larger EHR companies, the smaller practices and hospitals are not able to keep up with the components of the system to develop a level of functionality that will improve that they can get the analytics and the reporting that will improve the quality within their practices. So through our CIN, we're trying to go along with the model that MACRA has around virtual groups, where a provider can be remotely and the resources are in the cloud, as Gary talks about, and the expense is lower, but they can really improve the quality of care to the patients and the outcomes, especially around certain disease processes. So high functionality to address chronic diseases. Chronic diseases, about 5% of the population accounts for most of the cost in our system. Most of those folks are in underserved communities, and those are that's the group that we're trying to affect with this model. So within the CIN, or the clinically integrated network, we want to make sure that it's a comprehensive record that follows the patients by having the connectivity at all points. That's at the hospital, that's at the clinic, that's at the radiologist, that's at the community-based organizations, et cetera, et cetera. That's at the jail. We have connectivity with the jail. That's with the EMS, the emergency management system, so that we can inform, exchange clinical records with the ambulance, but also get that information from that particular incident with the patient and put it into a database that can be shared with the primary care physician whose patient may be have made an emergency call. So these are just some of the things that we're doing in the network. And we have a unique population to serve. And within that population, we think it's unique that we're nimble. There's no organization that's too small, no organization that's too large. As I stated, the practices that we aim to support, we want to make sure that we're bringing the technology at a reasonable cost that they can afford in order that they can stay in business and turn their attention away from maintaining the technology to actually taking care of the patient. And how do you keep these practices sustainable? And sustainability, you know, the doctors and the providers and the health professionals, they're clinically trained and they have the expertise to take care of the patient, but they also need the technology so that they can measure and also implement programs that can improve the outcome. So we're here to aggregate the data and provide them connections to labs, immunizations, and the ultimate goal is to provide a longitudinal record that at any point along the integration within the clinical integrated network that you're able to access the information, accurate information in real time. Next slide.
Great, thank you, Dr. Mack, and appreciate you sharing again your real life experiences of what you've done. And I think, one of the things that you'll see as we sort of flip over to the technical aspects of what's going on is the success that Dr. Mack has had, and this relates to the cost as well as the technical aspects of the cloud-based model. But for the purposes of education of what's available out there, I'm going to be covering what the requirements are to provide this connectivity, regardless of the type of clinically integrated network or ACO or environment you're in, and then share with you details about your choices from an industry standpoint to take advantage of that. So I'll use a case study as well. One of the main things that we're really doing when we're looking to exchange information is tearing down the health data silos. We all seem to know many sources of data, and as we've broken down the barriers of an individual institution like a hospital, there are other institutions that we have to communicate with, such as insurance for claims data. It could be that we're working with life sciences, pharma and biotech for purposes of clinical trials. And to improve the care, the overall care, and reduce the cost, we have to be able to take advantage of as much data as out there, including, by the way, social network and other information which is now available, and transform it, putting it together or harmonizing it. But as part of that, to be able to share the contextual aspects of the data to understand what we're doing and use it in a variety of ways. And so while I would venture to say that most of the organizations that are participating in today's call are from the healthcare side of the equation, there are other individuals that look at this, peer into the same needs here from a life sciences or translational science standpoint. So this will affect there. So one of the key things is moving beyond the boundaries of the four walls and supporting external integration. And so what we've seen over the years is it was easy when paper files were there, and we'd go to the records room and grab that file and move forward and pass it around. But now we've seen the movement to move that information electronically. And so we've seen great progress over the last 6 or so years in hospitals. The majority, a large percentage of hospitals in the United States, and for that matter, many of them in the forward countries around the world, moving that data to electronic so it at least exists in an EMR or an EHR. But the challenge is you lose control, if you will, or the ability to move that data when you're going outside of the boundaries. So this is an important requirement. And at this point, when you're trying to leave the four walls of the business, you now have to maintain profiles of those partners, determine what their IT capabilities are. So in a large hospital, there's probably an IT team. They may have an overwhelming portfolio of things they're working on, but you could also be dealing with a small practice that only has a part-time IT individual. You need to be able to understand what the capabilities of the EMR are, what's the connectivity options to exchange information with them. And we're going to cover some of these in detail. What are the types of documents and the formats of those documents, determining the context, how do you translate, transform, and harmonize information for review. And then finally, as I mentioned at the opening, for any of these models in ACO or clinically integrated network, what is the mechanism for the reporting aspects of it, to the metrics to improve the overall care. So there needs to be a process, and while I don't expect you just to see the detail in the diagram to the right, there has to be a process to bring those partners on board, and this is, involves both people, the process itself, and technology to make this smooth. The electronic parts of this can help map it out, give status and reminders and alerts to move along the system, and then of course, finally on the right-hand side, to go live for an ongoing monitor and continual exchange. The next piece is putting the pipes in place. So, when we look at the easy stuff of supply chain or financial services, pipes have been put in place to connect up and down the supply chain to exchange simple documents like purchase orders and invoices and acknowledgments. But in healthcare, those pipes really, for the most part, exist only within an individual institution. In other words, connecting throughout a hospital or a healthcare system. And so connecting those ways, you have to be able to support any type of transport or connectivity protocol. What are the ways to do it? So it could be MLLP, it could be secure FTP or secure HTTP, AS2. So as you look to supporting the environment of a clinically integrated network, not every institution, organization, physician's office, or practice will have the ability to exchange information the same way. Some won't have secure FTP, or some are going to say we want to use MLLP. And so you have to be prepared to deal with a variety of pipes. A lot of times I'll use an analogy of, going into Home Depot where there's a large pipe and a plastic pipe and a PVC pipe, and you need to be able to support whatever type of pipe that partner and those organizations that you're connecting with will be part of. So being able to do that. The second thing is, now we have a pipe. Let's assume we have a pipe in place, or a variety of pipes for that matter in place. We're going to pass information through the pipe itself, right? So it could be water, it could be something else in the analogy, but here we're taking data from a database, could be a flat file, could be an Excel spreadsheet. Much of the world runs on Excel through email, and we're moving to a model where, based on the data that we're providing in there, it needs to be secure and locked down because it's PHI, or patient information. So on the left-hand side, we talk about a bunch of different sources in the way information is formatted. And the right-hand side, it's some of the standards. And at the beginning, I mentioned standard being the only one word oxymoron. So if we look at any one of these, HL7 as an example is a great guideline. It goes down to individual documents in an XML standard, and within those documents, the fields that are there. But that's not to say that different institutions use those fields slightly differently, or the information that they put in there isn't the exact same way that the information is. And I'll talk about the context in a minute, but for instance, the fire at the bottom is a derivative within the context of the HL7. If you deal with clinical trials, again, patient information being exchanged could be from a hospital or healthcare institution, and that's CDISC. So depending upon the way you're using this patient information, there's a variety of different formats for the documents or methods to exchange those documents. And so IHE is another one that's popular. So I've only included a few of them, but the solution that you take, whether it's on-premise or in the cloud, and we'll talk about the cloud-based models, needs to be able to support any type of format that is out there. So let's talk about applications. The world is moving from an application-centric view to a data-centric view. And what I mean by that is, historically, organizations have gone out and bought a whole bunch of applications to solve problems, and then the biggest problem is, how do you get them to talk to each other, because the data within them is sort of bounded or locked in them. And so as organizations mature and look at this, what they put first is the idea of the data, as we're talking about today. How do you put basically a data layer in place so that no matter the type of application that you're using, you'll have an easy mechanism to be able to do this. And so this is a variety, with the big ones on the left, but the smaller applications, if you will, or the long tail, goes on for hundreds, if not several thousand applications that are out there, and they're for different purposes and different uses. In this case, it may be HIS, an EMR, EHR, lab information system. And then there's the whole reporting aspect of it. There are specialized systems for ACO reporting, the metrics based on clinically integrated networks. So each of these is going to have different capabilities, and what we're striving for here in this platform to be able to support the interoperability and the exchange of the information is the focus on the data. And a simple analogy that I use when I'm not in super techie talk is a housing community, in which they've put in the infrastructure underneath there for water, sewer, cable or internet, and telephone, those kind of things. And you can build a variety of houses on top. As a matter of fact, in older communities, they'll knock the house down, but they don't necessarily have to tear up the whole community from a sewer standpoint. And so that's the model we're moving from, the former, where everything was trapped in applications, to more broad applications. Some of these applications being on-premise, and other applications actually being in the cloud. So now we not only have to be able to support the interface of these systems, but we need to be able to support them whether or not they're within a given enterprise itself, or organization, practice, whether it's acute or ambulatory, or whether it's a cloud-based application that is running and people access that information. So now we have pipes in place. We're exchanging information in a variety of different documents, and we know that we have to be able to support the formats of the documents and be able to get information in and out of applications. So we're talking to each other. And so now we get to that next level, which is what is the meaning of the actual words? What is the context of the information that's in there? And you need to be able to have apples to apples as you look at this. And so this, comes into the translation of data, and other terms that come to mind are classification, code sets. And so here are some of the ones that are out there. And much like a standard, there are multiple standards as it relates to these. And so, for instance, LOINC, how do you say glucose? I always mention heart attack has about 37 different ways to explain it. And so not every EMR application is going to, call it a heart attack, cardiac X, cardiac Y, etc. And so we have to be able to make sure that as we're bringing together a variety of organizations, physicians, to be able to exchange that information, we understand that it in fact is glucose in all of these situations. And so more different dictionaries, if you will, to create those. And one of the key things that happens here is the development of what they call a crosswalk, the ability to have basically a mapping between, as an example, ICD, and we went from ICD 9 to 10, which has its mapping in itself, but between the ICD codes and SNOMED, for example. And so those are crosswalks that we have to involve to be able to accommodate the exchange down at the actual data level itself of how we're using that. So again, I like to throw a simple term in there, and it's like different groups or states or countries now within what was formerly Russia, and they're all speaking Russian, but Ukrainian and Latvian and Lithuanian and Belarusian all have different terms, and you may be able to get by and understand generally, but in the world of science and care of patients, we need to be more exacting. And so this is the translation between the dialects so that we know when we're analyzing patient data and we're doing research and or reporting that information out, we can understand the context of the data itself from a translation standpoint. And the next is the actual reporting of the applications. And so what becomes of interest here, I've mentioned a few of the terms on the left: population health, healthcare analytics, health insurance. There are a bunch of different applications that organizations or methodologies, if you will, want to report out. And some of the graphics that I'm showing, again, I don't expect you to see the detail, but we're taking as an example in the top center information from Twitter and graphically showing whether the surveillance of the information is of value out there, whether the sentiments of what's being provided out there on the social networks is positive or negative, giving feedback to both healthcare institutions as well as pharma. The phones themselves are no longer just simple calling devices. As a matter of fact, I think for many individuals, the phone itself is no longer first and primary a phone for talking, but in fact, it's the application that allows us to provide input to data, to run a glucose test, and provide that feedback back. There are now applications that allow us to bring in, take videos of patients or take pictures of problems we have and apply AI and machine learning to that. So now we have no shortage of inputs, and then of course the app outputs. And from an interoperability standpoint, we need to be able to support a variety of type of data, whether it's unstructured, like clinical notes, whether it's semi-structured, or an image for that matter, or very structured that we have. And the more information we can get about it, the more useful it is for that information. So you can't have a conversation when we begin discussion about patient data and also the cloud, and that is the actual compliance needs. And compliance goes under the idea of both security, privacy, and compliance. And you have to be able to protect the patient data. And the secure data management takes not only one approach, but you need to include both people, process, and technology. And this is whether or not you end up with a software-based solution that you and your organization is maintaining, or a cloud-based solution. And so here are some of the examples that are out there from an infrastructure standpoint. As an example in the middle, for control of SOC testing, you'll see out there. HIPAA, of course, in the United States for healthcare. If you're meshing it with financial information, you may have to participate in PCI for credit card protection. If you're dealing in the clinical trial process, maybe your healthcare organization is going to help team with pharma for clinical trial research or your site. And so as part of that network, 21 CFR Part 11 becomes important for validated systems. And then finally, for global information. So the safe harbor that was previously out there has been replaced with Privacy Shield. And so all of these different types of, if you could look at it, standards for protecting information, many have overlapped to how they're doing it, but just like we're talking about for protocols and document types, they all have special differences that allow us to achieve that, and they become important. So if and when you're dealing with this information outside of just basic financial, if you will, looking at these and getting that as part of both the on-premise and the cloud-based is an item that has to be dealt with. So let's talk about making choices for solutions. And I think the first thing you have to look at from consideration of how you enable is whether or not you want to be in-house, the way organizations have in the past, or look at cloud-based solutions. And you'll often see, you know, oh, we don't deal with the cloud, everything has to be here, and we also see a backup of that. And then as I have dialogue with different organizations, I'll ask, you know, what's your EMR, you know, where are you running it locally, and as it turn out, well, it's actually in the cloud. So we have to get a clear understanding about what we mean in the cloud. But 5 or 6 years ago, I would have said, we often have to explain how, you know, what the cloud is and the security around it. And more often, individuals are getting much more educated and have a comfort in determining the cloud is a safe place. And for that matter, lots of information of patient data is being stored in the cloud for EMRs, EHRs, reporting applications, and the like. So here's some of the questions that really need to be asked is, you know, what are the strategic IT priorities of your organization? Is your differentiating factor the fact that you're going to do analytics and analysis to try to improve the patient care, or is it trying to build these connections in to different sites? The individuals that are within your IT organization, what are the skills level? And of course, the workload. And I can tell you, you know, that starts in the clinical aspects where, again, they're not meant to be experts in IT, but we're pushing them in that direction. We want to make their job as simple as possible. Do the individuals that would typically deal with this, do they have the time and the ability to keep up with the current standards, the technologies, the protocols, and that information to be able to deal with it? From a financial standpoint, as you engage, and again, you know, if I were to look at a hospital as an example, many of them have legacy systems that have been out there to solve the integration problems within it, you know, such as a Cloverleaf or Oracle eGate, but they don't solve the boundary problem that we mentioned before. So how do we deal with that? So when you go to upgrade or change, do you have money from a CapEx standpoint to invest, which is what often in-house software is, or would you rather run it as an operational expense over time, which is more like a lease on a car or furniture, where you're paying it off over time for the use, which is the cloud-based model. And those have become much more common, much more easy to make an ROI business case as you're paying as you go along the way. And finally, as we covered in the last slide, you know, what are the compliance, security, and privacy requirements, and then the cost to maintain them. It's not going to go away even if you choose to use a managed service and a third-party provider, but your cost can go down a whole lot. And you can shift the burden, if you will, of all those pieces and putting together those documents and third-party assessments so that you can gain the use of that information in dealing with a cloud-based provider for that. So, you know, sort of peeling back the onion, if you will, from a technical standpoint here, there are different ways when we talk about the cloud itself. And so what we have is on the first-hand side, you'll hear infrastructure as a service. I call this the blinking lights. And so you're renting servers, Amazon Web Services or Google or Microsoft Azure. You're responsible for everything above the hardware itself, and then you take advantage of their platform. The platform as a service is what I'm going to focus on in the model that Georgia Heath Connect uses, where you're not only getting the service in the middleware, but there's often people, experts that are there to help you out. And so we'll talk about platform as a service model for the purposes of integration, interoperability, and data management. And then finally, there's a SaaS model where you're buying an application that includes all those other pieces. And so there are EMRs on the right-hand side or a reporting application, but it doesn't solve the integration problem itself. And so we'll look at these three, but we'll have a focus on the middle where you can license an application like an EMR or an ACO reporting package that is in the cloud to minimize your need from an IT perspective. But to actually integrate, there are some simpler ways in a platform as a service model to be able to do that. So as we have covered from the beginning, data is really the key here. And so we're building out a data layer. And effectively what we do in that middle model that we saw before, the platform as a service, is really a center on data, what we call data platform as a service, or DPaaS. So we're utilizing the platform service to perform the integration, to harmonize or blend the data, and allow it to be analyzed regardless of the type of application that is in the target itself. So I'm not going to go through the bullet points on the left here, but as we deal with those, it's many of the things that we've covered. And by utilizing a multi-tenant cloud-based environment with services, that allows you to achieve the integration that's needed, whether it's with a large hospital or healthcare institution, or as Dr. Mack was referencing from Georgia Heath Connect, a small rural practice. So again, back to analogies to make it simple to understand these technical concepts. Changing oil. You know, I can change my oil. I did it when I was a kid, and then spend time putting the car up on ramps and then getting underneath there and getting dirty and all that kind of stuff. And it would take me a little bit of while, but I would do it, and I'd get my oil changed. And it was probably the cheapest way, but it also used a lot of time. And enter Jiffy Lube. And all day long, they are the experts at changing oil. So for a few dollars, but a lot of saved time and effort, I can pull into a Jiffy Lube, and all day long, they're going to change oil, and they're the experts at oil. If you need to change out your alternator, they're going to say go to another expert. And so what we're talking about here from a platform as a service for the data is there are organizations like Liaison that effectively have expertise in a cloud-based model to provide the integration and the interoperability and the transformation, the translation, the security and compliance, and these needs in an operational model to be able to achieve that in the quickest way. So I'm going to transition from the requirements itself and sort of recap on just a couple of slides here how this applies to the clinically integrated network using Georgia Heath Connect as a model that we've seen out there. So as a result of leveraging a platform, in this case Liaison's platform, with the overall branding and interface for Georgia Heath Connect, we've streamlined the data sharing between the different settings, the different EMRs, the different providers that are out there, providing really aggregated view, working towards a longitudinal record in a bi-directional exchange of information. So it's not just one way. For those individuals that can, those organizations and applications that can handle it, we deal with the bi-directional, of course, give an alternate of a portal view to gain access to that information. Georgia Heath Connect can deal with a variety of types of data, different sources, both financial as well as patient, and has a patient repository that in their requirements needed an IHE exchange for that. So that's one of the standards for the interoperability of information between different institutions, and that's used as an example for the overlay to GHIN and the surrounding states and federal aspects of it, and then the different standards for that information, all done in a secure way. So from a overall picture, we're taking clinical, financial, and other data from provider organizations, both large and small, throughout the Southeast primarily, and then within the state of Georgia for Georgia Heath Connect, giving access to provide the data to reporting and analytics applications, as well as a data viewer to see the actual records. And then on the right-hand side, the interoperability to Georgia HIN and the surrounding area networks for that. So in the middle is Georgia Heath Connect. Underneath the covers of that, we deal with the platform, which is hidden, but allows that, again, seamless integration and interoperability to whatever's needed. So what you can't see underneath the covers that is leveraged as a result of going with a platform as a service provider is things like patient and provider indexing, healthcare terminology management for the crosswalk between the different terms, the transformation, the translation of the actual documents, the formats of that information, taking in all types of feeds on the left, going through the environment itself and outputting on the right to whatever applications are needed. And again, as Dr. Mack listed, some of the inputs and outputs include EMT applications, lab applications, clinically integrated network reporting, PQRS, and of course, for those individuals that are dealing with MACRA, formerly the meaningful use piece that's now been rolled up, the metrics as it's needed for that information. So finally, the last slide, and again, clinically integrated networks are really just one example of the many models that are out there that require the data exchange. There's a bunch of different types of applications, EMRs and HRs, and they have a universal challenge of getting data in and out in the formats that inhibit the easy interoperability. Waiting for standards will never be the solution. Organizations say, you know what, I think the standard is going to solve my problem. Well, in supply chain, we've been dealing with standards for over 30 years, and the standards continue to evolve and evolve with different needs, but we're never done. And so you need to be able to deal with the standards, whether it's integration protocols, the document format, the terminology itself. Cloud-based solutions reduce the internal IT requirements. They speed up the implementation. You're hiring the Jiffy Lube of changing oil to be able to deal with the pains of all the requirements that we've dealt with, and the ongoing maintenance and monitoring of the transactions to make sure that they're flowing, and allowing your organization to spend more time, being a data scientist, focus on the metrics and improving the patient information on the patients themselves, the care, and no longer be spending the majority of their time, or 80% of the time, trying to get the data ready and acting as what we would call a data wrangler or data janitor. And then finally, the platform as a service model allows you to use that expertise and, again, addresses regulatory compliance needs at a scale level. So the clinically integrated network utilizing the cloud-based model can meet whatever needs you have, whether it's a MACRA or quality initiative or an ACO from a reporting standpoint. So with that, I'll turn it over back to Lori to see if there are any questions that folks have, and Dr. McElbrine would be happy to answer it in the final few minutes that we have.
Thanks, Gary. We do have a couple of questions. As a reminder to attendees, please use the questions section in the GoToWebinar panel to submit them. The first one looks like it's for Dr. Mack. The question is, how are Georgia Heath Connect technology solutions assisting with population health management?
Good question. Basically, what's happening with the solution, one thing is the connectivity. With population health management, you have to begin to measure clinical activity or your clinical interventions, or just understanding who your population is, and that requires data, especially in this day and time. So it's multiple ways, but one thing is, who are your patients? Like, for instance, who's a subpopulation like diabetics? And then you can look at how well those diabetics are being treated. How well are the measurements when you take the labs of the hemoglobin A1C. And then you see gaps in care where you can identify those patients that really need better intervention, more attention in management, and then you can kind of put your interventions in place and then hopefully improve outcomes, but measure the improvement of your outcomes and then try to improve the process all over again. So it helps with population management from a practice, what we call practice-based population health, but also it can help when you get practices across the state, across the nation, reporting information through health information exchanges or clinically integrated networks, whereas at a public health level now, you can see how the population is doing, where the flu outbreaks are occurring, how you can address that, etc.
Thank you. The next question asks, the topic today focused on clinically integrated networks. How does that compare with ACOs? Is it the same needs and challenges, or are they different?
Yeah, so the requirements that we covered today are very much the same, and so again, I think both of them are very much metrics driven, depending upon the formation. The paperwork, if you will, the legal aspects of the entities are very different, but from a technical standpoint, they're actually identical. And what I would say is, you typically have your different inputs and outputs. The inputs are a lot of the same, different EMRs and different applications. On the reporting side, there are some specialty applications that are out there, like Lightbeam and others, that are specific for ACO reporting. And so getting the data into that format from a variety of different EMRs, EHRs, both ambulatory and acute, to get it ready is the challenge that you're meeting. And so the requirements that we have today is exactly the same from that standpoint, from a clinically integrated network. So Good question, but yeah, the challenge of the formats and the pipes and things like that are exactly the same. The difference is what information is used in the output, but the challenges are identical.
Okay, the next one. With accurate analytics as the goal, what services and actions do you empower to ensure your data normalization for all of your sources are normalized?
So I can address that one.
Yeah.
So I was going to say from a technical standpoint, the first thing is one of the things is changing. I think what key to there is the data sources and normalizing the data. I think the model is changing as formally, and again, I don't want to cover too much from a technical standpoint, but the model used to be extract data from a source, transform it, and load it into a given data model. That's really an application-centric view where once you've done that up front, you've forced it into a given situation. That's really where the world is from application to application, and as they're going to create this clinic integrated network, the challenge is that data is bound within the data structure. So what's changed is organizations are going to more of a data platform as a service model where it's more of changing it to a data lake where we're extracting and we're loading all the data in its raw format, and it's only later on that we transform it. So the ETL is changing to an ELT, and where that becomes important is we actually don't know all the questions down the road that are going to be asked of the data. So instead of bounding it into a specific schema or structure when we first load the data, let's do it later on. And so that applies into then the normalization of the data. And so sometimes we'll put indexes and graph methodologies in place so that the data appears to be normalized, but we don't want to lose the source and the context of the data the way it was. And so it's a combination of, yes, there's some normalization that goes on, but you don't want to lose the ability later on when a new clinical question comes up to go back to that original data source and look at it in a different model. I'm not sure if that answered the question or if Dr. Mack had anything else to ask about that.
No, I think that's good.
Okay, it looks like we have time for one more question. The last one I'll ask is for you, Dr. Mack. How is U.S. health policy helping with the adoption of new technologies such as CINs?
It's supporting it in many ways. I'll go back to the question that Gary asked us. I think when you look at the ACOs, you can be part of an ACO and you can report in many ways. The thing is how are you addressing the health of the population and how are you measuring that and reporting on it? And you can do that within the clinically integrated network. So what they're doing with the policy around MACRA, meaningful use, as we stated, the new MACRA policies are combining meaningful use, PQRS, all the other quality programs that providers were required to be a part of as we move to the value-based system. The connectivity of information across this country, and then, of course, moving to where you're analyzing, you're reporting, and then, of course, to a level of predictive analysis, that really helps to measure and improve the health of the population. So the clinically integrated network is one model where providers who have a common interest can take care of subpopulation of patients.
Great, thank you. That was our last question. So with that, we'll conclude the webinar. I want to thank everyone for joining us today, and thank you, Gary and Dr. Mack, for the interesting and informative presentation. As a reminder to attendees, watch your email for links to the recording of today's webinar, as well as the PDF version of the PowerPoint presentation. We look forward to seeing you all at our next HIStalk webinar. Enjoy the rest of your day.